at a time when many people were sort of saying, it's going to be okay.
Mhm.
Was it a difficult decision? Did you hesitate? Walk us through that.
So I want to first highlight that public health is a very collaborative enterprise. The culture is collaborative. The way we do our everyday work is collaborative, and this decision was no different. And so, in many ways, I think that for whatever reason, I've been the face of it, but it wasn't. It was really not me. It was really an entire group of us. We had been watching very carefully the trends really around the world since early January. And then in late January, when we became the first jurisdiction in the Bay Area to have a case, we began, we've been thinking all along about the various steps that we were going to need to be taking, but particularly after those first two cases, and even more so when we had our third case, where we knew that it was community transmission, we knew the virus was circulating at some level in our community. That's when we really started to turn things up. And so in some ways, when we came to the point to make the decision to shelter in place, it had been after many discussions and a lot of thought, and it had been a decision we thought we might ultimately take. So it may have seemed precipitous to the outside world, but it wasn't on the inside.
And you talk about these stakeholders, and I know often it's framed as if the public health officials shut down the city, but of course you're really working with government officials to shut down the city. Were they part? Who else are the stakeholders in these kinds of conversations? They have other pressures, right? Which are people need to work, who should actually be going into work, who needs to shelter in place, et cetera, et cetera.
Right. Well, I think it looks a little bit different in every part of the country. In California, the local public health officer has a lot of power and authority to make these types of decisions and to issue orders, and they're legal orders and they're enforceable. So in our state and in our region, we don't usually use those powers. In fact, I can remember when my son was little and he was asked to share at school, one of the things he said was, "My mommy has police powers, but she doesn't know how to use them." But anyway, I've learned. I've learned. And what I mean is that my colleagues around the Bay Area and around the state, we're a small community. We know each other really, really well. And so we've been talking about this, many possibilities for a really long time, and not just with each other, but of course with each of our teams and our public health departments, with our partners outside in academia. Lots and lots and lots of different brains helped us inform this decision. As far as being able to implement the decision, it really is, though, it does become a whole of government approach. And none of us could have implemented this decision without many, many, many others behind us. And chief among them, actually, I would say, is our attorneys, our county council, who made sure that we were doing things in a way that was clear and enforceable.
March 16th, you had specific shelter in place orders. You had to tighten them up again, actually, approximately 2 weeks later. What were you finding within that 2 week window?
Well, we crafted our orders in a 24-hour period because once we decided to all hold hands and jump, we needed we needed our respective counsel to draft these orders, and they were pretty darn good. But once we were implementing them, we discovered that there were some loopholes, and the bottom line is that there were more people out and about having contact with each other than we wanted to see, because our top line goal was to just dial things down so that people were having less contact with each other and only having contact with stable groups. One of the things that turned out to be challenging was for businesses that are essential, for example, grocery stores, really hard for them to ensure that when people were in the grocery store shopping, for example, that they didn't, run into each other. So we put some, a little bureaucratic, but we thought hopefully helpful instructions on exactly how to implement social distancing.
And is that the most essential thing in this crisis, whether you're in the Bay Area or I'm in the New York area? Stay home, just stay away from people?
Yes, because this is a brand new virus, and around the world, still very few people are immune. Because the only way you can become immune is if you've already been infected. There's no vaccine to give you immunity. And so, we don't know the level of immunity in our population. Not those studies aren't complete, but I think we just have to assume that most of the population is, if exposed to the virus, likely to become infected. And so it's a drastic move to ask everyone to stay at home and shelter in place, but that's our best tool right now to settle things down. And so after we settle things down, one, maybe there'll be other tools that we have. For example, if we had settled things down and had a lot of testing, we might be better able to be more focused in our efforts. But once transmission and the spread is widely occurring across the population, you can't do those focused efforts. You really have to do something population wide, like ask everyone to stay at home.
So what's happening with testing here in New York, for example? If I wanted a test, but I just because I thought I might have COVID-19, but I hadn't sort of hit all of the risk factors, they would not give me a test. It certainly wouldn't be easy. What's the situation in the Bay Area, and how is that going to impact how you're able to really track this disease over the long haul?
It is a significant problem. It's a tool that we've needed and we still don't have. My sense is that the availability of testing in New York is actually greater than the availability here where I am in the Bay Area. Um, we're now keeping a dashboard on our county website, and I think maybe just 13,000 people or something like that have been tested so far, and we're a population of almost 2 million. So what we're needing to do still is prioritize. Think, who is it that we most need to know whether they're infected or not? For example, if someone's in the hospital and they're ill with something that seems like it's COVID, we really need to know if they have COVID. Um, if someone, for example, lives or works in a skilled nursing facility, we really need to know if they have COVID because there's actions that we need to take both for that person and for the people around them. But as far as it being widely available, it's not. That's the current reality, and I'm still hopeful that somehow testing will be able to scale up because it's a tool that we really need for prevention and control in the future, now and in the future.
And accuracy. I mean, if someone dies and it's unclear if they died of COVID, how do you ultimately get true numbers of infections? I would imagine that's going to be challenging.
Yeah, I think among people who have died, we probably have that's probably the most complete data. Um, to some extent, most people who are hospitalized were able to confirm whether they have COVID. Those data are pretty complete to help us understand. But for everyone else, it's a little sketchy
Mm.
to really be able to accurately track the trend.
We often talk about the social determinants of health, which
Mhm,
for public health people makes a lot of sense. For
mhm.
non-public health people, they have no idea what you're talking about. So explain what that is, and then talk to me about some of the challenges you're seeing that are the social, that are bringing in the
Right.
social determinants of health.
So the social determinants of health, like housing, education, transportation, all of basically the basic structures in society, those all determine our health. They might improve our health or they might harm our health. And so what we're seeing with COVID-19, which is what we see with many diseases, infectious and not, is that people who have structures stacked against them, either through institutional racism or policies and practices that have occurred over time, they disadvantage some groups over others. And what we're seeing with COVID-19 is that, for example, in communities that are low income, communities where people are living in crowded conditions, that is facilitates transmission and spread of this virus as it does for many infectious diseases. And so it is not impacting everyone in the same way. And so we need to develop strategies to be even more protective for certain communities.
When we look at Louisiana, when we look specifically at Milwaukee, for example, we see that African Americans way over index in
Mhm,
vulnerability to COVID-19 and frankly,
mhm,
just death. I mean, I think it's something
mhm.
like 70% of the deaths are African American when the population itself is only something like 32%. Is it as simple as pre-existing conditions and people who are just more vulnerable socially, or is there something more complex at work that we just don't know yet?
So I think, of course, we'll have to really dig deep into these data to ensure that we really understand what's going on. But if this pattern is similar to any other pattern, it likely has to do with communities who are disadvantaged and have been disadvantaged for generations. One, more likely to have chronic diseases, diabetes, asthma, obesity. These chronic diseases are much more common, and there's structural reasons why they're more common. And then if you layer on top of that an infectious disease, particularly ones that's going to spread even faster in crowded conditions, then there you have the perfect storm. I would also add that at least I know in our county with our shelter in place order, we have said there's essential activities that need to go on and essential businesses that must occur. Well, many retail clerks, that's a low wage job. And so if you're out, serving the public, performing essential work and a low wage job, and then you return to your home and your home is crowded, one, you have a higher risk of exposure, and two, you have a higher risk of spreading infection at home. And this is a very, very difficult challenge, and one that we simply need to face and address.
Certainly in New York, add to that, you probably took public transportation to get there. You probably overlap with a lot more people than if you had just hopped in your car. So I fully.
That's right. That's right.
Can you explain to me what antibody testing is and where are we with that? Would that be something that would be helpful to you?
So I don't have a lot of expertise in this, but there are a number of different antibody tests that have been developed. Those are tests that look to see whether your body has developed a reaction to the virus. So it's evidence that you and the virus have met before. I guess is the simplest way to put it. And so it's a blood test and it looks for different types of antibodies. Some are markers for you've been infected recently, some are markers for you've been infected in some time in the past, it's time unknown. There's lots of work going on. Lots of different antibody tests have been developed, but there's lots that's still unknown. For example, if you identify an antibody, does it mean you're protected? Does it mean you won't get infected? If you are protected, how long does that protection last? And many of these questions have not been fully answered.
Are you guys advising everyone as they are here in New York to wear a mask anytime they're out or anywhere close to another person?
We are. What we're advising in the Bay Area and I believe across California is to cover your face, or we say cover your nose and mouth because you don't really want to cover your eyes. um, but we also need to balance that with the current reality, which is that we don't have enough medical grade masks and N95s for people delivering care to those who are sick. And so we're calling them face coverings, even though technically we're just asking people to cover their nose and mouth. And there's been a whole,
A face
yeah,
covering, because I have some sort of knockoff of an N95, which is called a KN95, which I'm sure is nowhere near as good, but it's all that I could find at the local store.
mhm.
Is a face covering effective? Is it effective for me not infecting other people? Is it effective for them not infecting me? How does that work?
So the face coverings are important as one layer in preventing the spread. So say I'm infected and infectious, even though I don't have any symptoms, and we know that can happen. If I'm covering my face, there's a lot less chance that I'm going to spread the infection to people that I'm with. It doesn't eliminate it, it just reduces it. So if population-wide, you have everyone covering their nose and their face, that adds an extra level of protection, such that if anyone in that group might be infected and infectious, they are less likely to pass it along. So covering your face combined with keeping your distance, and only being with people that you absolutely have to be with, all of this together helps slow things down.
What is the long-term assessment of where we are in terms of a vaccine, or if there's going to be a second wave? Are we going to shelter in place as you're doing in the Bay Area and we're doing in New York
Mhm.
forever? Am I going to be overseeing online school for 4 people for the rest of my life? How's it going to work? Because it feels
Well,
right now, to be honest.
I know. I wish I had a crystal ball. It may look a little different in different parts of the country because I think that we're all in a different place with this with the pandemic. I think one thing that I say to myself and to my family and to my colleagues is that we're living in an unprecedented time with tremendous uncertainty. And at some level, we have to start getting comfortable with uncertainty. As terrible as that is, that's kind of where we are. So we are collaborating with modelers. Most health departments are collaborating with modelers to try to get insight into where this is going and give projections. But they're not precise. They're they're just models. So they will help us plan. We're all trying to learn from each other. We're all trying to learn from experience in every corner of the world. But there's a lot of uncertainty. So it may be that we can slowly lift some of the restrictions that we have now, especially if we have the tools to be more focused. Um, and it may be that if we do that too fast, that we'll have a resurgent and then we'll be back to where we are.
Some states have been quite lax about shelter in place orders, or even wear a mask or don't be around other people kind of orders. Other states are far more stringent. How does that complicate your job and the job of every public health official if over here are the rules, and over here, almost the opposite rules are applying for, Americans move pretty freely between
Mhm.
states and cities if they want to or if they have to.
Right. Well, we are. This this is one of the complexities of trying to manage the pandemic in the United States of America, where we have local and state control. So we're all going to do it a little bit differently. And even if in the Bay Area we executed perfectly and everyone stayed at home and didn't move for a month, and we were able to settle things down to how it looked in January. That's not going to be our reality because people need to and will move around. So there'll be likely continual reintroduction and reseeding in our community, as in many communities. So I think it's going to look a little uneven and a little bumpy as we go forward.
Have you been able to flatten the curve in the Bay Area, or do you feel like you're on the other side of the peak? Everyone talks about sort of the peak
Mhm.
number of deaths, and in New York City, it's people are literally, I think, panicked about it, and every day we wait to see kind of how the day ends with the number. Where are you guys in that curve?
So one of the metrics that we're looking at is the doubling time. That's the number of days for the number of cases to double. And in early March, our doubling time was around 2 to 3 days. So at that point, we had made recommendations, we had made urgent recommendations, but we hadn't issued any orders. And then over the first half of the month, we were issuing those orders, culminating in the shelter in place on March 16th. And what we've seen over the course of the month is that the doubling time has lengthened from about 2 to 3 days to over 2 weeks. So we do have a signal that we've really slowed things down. But as far as have we reached the peak and when will that be, that's quite a bit more uncertain.
If I were to walk outside and bump into people, which I wouldn't do anyway, but hypothetically speaking,
Mhm,
I think most people would have no idea what public health officials do and
mhm,
wouldn't even really know what public health is, certainly before COVID-19. Do you think this has
mhm,
changed people's focus on public health and support for public health? Public health funding, as I don't need to tell you, has
mhm.
been cut for years and years and years
Right.
under Democrats, under Republicans. It's just sort of been cut. And I think part of that is that the public doesn't really know what it is, so they don't feel like they need to stand up and defend it, if you will. Do you think this is going to change how people think about public health?
I sure hope so. I sure hope so. We always say so. Our job is to uh, prevent bad things from happening, right? Our job is to look at what can we do to prevent disease and injury. And when we're doing our job well, what you see is nothing. Right? That's sort of the paradox of public
Yes,
health.
but that is often the
Right.
problem, right? Is that no one,
Right.
I used to
Right.
say it's a lot like a TV assignment desk, right? When it's going smoothly, everyone's happy, but they don't really realize why. When it's
That's
going
right.
horribly awry, suddenly everyone discovers the assignment desk is messing.
Yes. Yes. Right. Right. We're a part of a very complex ecosystem. Um, and in public health, one of the core things that we do is prevent and control communicable diseases. And we have to be absolutely on our A game. When that happens, it's public health, it's our responsibility to act. It doesn't live anywhere else. It lives in public health. It doesn't live only with public health because as with COVID-19, it really becomes not just a whole government approach, but a whole community approach to slowing the spread. Um, but there's many, many, many other bodies of work that public health does. And we talked about one of those earlier, which is how can we ensure that communities are healthy, whole communities are healthy? How do we ensure, what does a healthy community look like? Is there healthy food for people to get? Do they have a way to get around? Do they have open space where they can exercise? Is it safe, et cetera, et cetera? So a lot of the work that public health does when we're not in this reactive mode, I think has helped to soften the impact, but clearly it's not been enough.
Final question for you. What do you need right now? If you could wave your public health wand and get something, supplies, anything,
Mm.
support, emotional support, financial support, whatever, what do you need?
Well, it's a pretty long list. It's a pretty long list, but
Top three things,
top
maybe I should.
three. Um, uh, Really robust data and information systems would go a long way. And so that a lot of public health decisions and actions are based on having quality information, and we have not invested in the systems to make that so. So I would say that is number one. Number two is relative to the value that public health brings to a community, the whole infrastructure, not just data, but just even like the number of public health professionals per capita needs to increase. It really needs to increase. Our job is, to the extent that we can, to put hospitals out of business, right? We're trying to keep people from being sick. And if there's a way to move the investments, what we call upstream, we would surely love to do that. And the other is that to strengthen we have really super collaborations, but they come about very organically based on relationships. But to make them more structured and more prevalent, I think it's important for every public health department to have a fantastic relationship with with an academic center. The back and forth, where the practitioners, our colleagues in academia, are the ones that are really thoughtful and studying and evaluating policy, and then we can help put things into practice. And so um, ensuring that those relationships are occurring everywhere, I think would be a huge benefit to public health.
Dr. Sarah Cody. It's so
Mm.
nice to be able to grab some time with you. I know you're swamped, so I'm going to release you so you can go right back to work. I so appreciate the conversation. Thank you so much.
Thank you so much. It was my pleasure.